Hey, welcome to episode 8 of the Go-To Physio podcast. My name is Dave O'Sullivan, and on today's show we talk about the importance of diaphragm and ribcage mobility for low back, groin and hip patients. I hope you enjoy the show. Hey, welcome to episode 8 of the Go-To Physio podcast. My name is Dave O'Sullivan and it's a privilege to have you here again for another episode. Now, we're going to shift gears again today. Last episode we had a clinical application where we looked at terminal knee extension exercises and maybe a little bit of a better way to integrate some of these movements. What I want to do now is I want to shift back to higher up the body, but most importantly, looking at the impact that the respiratory system in particular has on the musculoskeletal system. So today's episode is all about the importance of diaphragm and ribcage mobility for low back pain, groin pain, hip patients, among many, many other patients. Okay, shin splints, a lot of the vast majority of clinical presentations. Hopefully you're going to be able to get something to help these presentations with from today's episode. So back in 2008, 2009, kind of breathing, the importance of breathing and diaphragmatic breathing, became quite popularized in our community for members around that time. And I played with it. And I'll be honest, I was giving people 3 sets of 10 reps of diaphragmatic breathing, and I was seeing some very, very mixed results. Okay, some people were getting great results. Some people, it was very, very short lasting. Okay, and it was quite frustrating for me at the time. As went through the years, then switched clubs, started to build a private practice and started to develop the step-by-step system that I now teach in a mentorship. I started then get a genuine kind of critical thinking, higher level thinking, if you will, of where this fits in the system. And that's what I want to talk about today, is the importance of looking at the person and appreciating that, a lot of the reactions that we're seeing in the physical body, it's not always got to, it's not always because a muscle is tight. A higher level question is, well, what's driving that? And that's what we're going to get deep into today. So when we look at diaphragm, okay, again, I was one that was trying to, isolate the diaphragm and get diaphragmatic breathing. And I think the big thing that I do now is I've kind of relaxed a whole lot on trying to isolate the diaphragm, especially when you appreciate that, the diaphragm, it's a workhorse, okay? As just like the musculoskeletal system, to a point, it's a workhorse to what's happening in the higher centers, okay? So we need to appreciate that breathing in particular, the vast majority of it's happening subconsciously, okay? Our breathing rate and our breathing depth is going to be in reaction to what's happening in the environment, okay? The environment that we're in at that particular moment. So, and I think this is why I got short lasting results, if I'm being honest, back in kind of 2008, 2009, around that time I was working with Leeds Rhinos and I was just starting to build up the private practice. And, it's all well and good doing diaphragmatic breathing exercises, lying on a physio bed in a nice calm environment. But then, if that person who's had maybe persistent back pain for a long time, they're going through a lot of stress at work, with their boss, etc. What happens to that breathing rate? And then as a result, the breathing depth when that boss comes towards them, okay? Or when they're having a, particularly stressful day at work, okay? That to me is more important than, just getting that person nice and relaxed in the actual, the physio environment. So I think that's the first thing that we need to appreciate when we look at breathing, is that, when you're doing your breathing exercises, it doesn't need to be specific to the environments that are ultimately going to cause that breathing rate and breathing depth to change. Obviously when someone gets stressed, or, I like to think of it as when someone's anxious, or, when we go to an extreme hyperventilating, we start to see the breathing rate change. So again, that kind of, panting, in a real bad scenario. And what we want to appreciate with that is what's happening at the diaphragm in reaction to the breathing rate. Okay, so again, the diaphragm's reacting to what's happening at the higher centers. When we go into that state of hyperventilation and when our breathing rate increases, we're shortening the diaphragm, obviously, and then the exhale isn't very prolonged. Okay, so again, we're trying to get more and more air in, but we're not getting a lot out, so to speak. Okay, so what the impact that is having is the diaphragm ultimately is losing the ability to lengthen. Okay, plain and simple. That's how simple I keep it these days when I teach this stuff, the more clinical applications of this stuff in the mentorship. Okay, so what's the impact on the diaphragm's inability to lengthen fully? Okay, well, what we're going to see is the receptors, the chemoreceptors. We've got a whole host of receptors in the respiratory system, just like we do in the musculoskeletal system. But a lot of these can get sensitized as well. So what you're going to find, and what I find clinically with a lot of kind of complex back pain patients, especially when you're really getting that diaphragm to lengthen, is they panic, okay? Because the diaphragm's not used to being in this lengthened position, okay? The receptors are screaming at the patient, breathe in, breathe in, breathe in, and it's a horrible feeling, okay? It feels almost like you're going to suffocate, essentially, okay? But sometimes we need to take these patients to these levels to update the belief system and to desensitize some of these receptors, okay? So kind of gone off tangent a little bit, but that's something that we need to appreciate, is that the diaphragm, it's just a workhorse to what's happening ultimately in the higher centers, okay? If we get these receptors sensitized, then the diaphragm, trying to get isolated diaphragmatic breathing, it's going to be of limited value in my opinion. Okay, and again, that's just my opinion, but from reading into this and spending a lot of time trying out these techniques, some stuff's worked well, some stuff hasn't. What I've come to realize is that it's not necessarily now about trying to isolate and get good diaphragmatic breathing. For me, it's just a very clean strategy of let's just get the diaphragm to go through a full range of motion, which as part of that full range of motion, that we're going to have to consider desensitizing these receptors. Okay, and then once we have that, then let's just get that person in these environments and then focus on what we need to focus on, okay, specific to that person's needs. Because what we don't know, okay, is ultimately, unless we get this in the subjective assessment, is what drove this sensitivity in the first place. And there's no two people are going to have, although they may look and present the same, like sway back postures, etc., these kind of hyperlordotic postures, whatever you want to call it, although they may present the same in the clinic, no two people are going to have got to these postures through the same stressors. Okay, so that's where the emotional stressors, okay, your non-physical stressors, such as, stress from work, life-changing events, trauma, all of these things, okay, they're going to have a big impact on our breathing rate, which is going to have a big impact on our breathing depth. Okay, so again, think hyperventilation, we start increasing our breathing rate, the breathing depth or diaphragm range of motion decreases, which is going to have a big impact on what happens at the rib cage, is what we're going to talk about next. So when we inhale, the diaphragm is going to come down, the rib cage usually is going to couple with an elevation, external rotation of the ribs. Okay, so if we look at the rib cage and what's going to happen at the rib cage, we see that when we breathe in, the diaphragm is going to shorten, the rib cage is going to elevate, the ribs are going to externally rotate, and we're going to get that protraction ultimately of the rib cage. Okay, if you take a massive breath in through your mouth in particular, you'll feel the reaction. Now, when that rib cage elevates, we're usually going to have a couple reaction of the pelvis. So when that rib cage elevates, that's going to drive an anterior tilt to the pelvis. Usually, if you're standing and you're doing that, you're going to see your weight shift forward, usually onto your toes a little bit. If you exhale, okay, we're going to get the opposite. So when we exhale, the diaphragm is going to lengthen, the rib cage is going to internally rotate, the press retract, the pelvis is going to posterior tilt. Usually the weight is going to shift back towards the midfoot. Hey, I hope you're enjoying today's show. For more clinical content and tips to help you implement this content in the real world, please visit thegotofysio.com for more information, including my 6-step patient adherence checklist, which you can download for free. And also there's more blog content that helps you implement this stuff in the real world. You'll also find links to my YouTube show, the Go To Physio Show, as well as lots of more information to help you become the go-to therapist, helping real patients get real results in the real world. So what we want to consider with that then is the impact that that's having on the peripheral tissue. So you can see if we have somebody who's maybe got sensitized respiratory system, they ultimately are going to lose the ability to depress, retract the rib cage. That's going to have a big impact on their length-tension relationship of the transverse abdominis, for instance. Okay, so again, when we exhale, the transverse abdominis is going to naturally shorten. The belly button's naturally going to get tucked in. Okay, when we inhale, okay, which a lot of people, they're stuck in almost hyperinflation. Okay, in my opinion, from my experience, that's going to have the diaphragm at an altered length-tension relationship. It's going to have the obliques, the rectus abdominis in a very long resting position, if you will. Okay, so again, I appreciate that, static postures and static, it only tells so much of the picture. But in terms of energy efficiency, I think this does have an impact. Okay, so for a lot of things that we're trying to do, okay, we're trying to get the glutes to fire, we're trying to get the TVA to fire if you're that kind of therapist. Okay, you're trying to get the abs to fire, you're trying to get the lower back muscles to relax. A lot of this can take place simultaneously by helping the diaphragm to lengthen, which is going to get the rib cage to depress, retract, internally rotate, which will get the abdominals to contract, okay, and actually do what they're supposed to be doing, okay. And again, the internal obliques are very, very important for getting that rib cage to depress, okay. Again, when we get those obliques to fire, then we're going to give ourselves a great chance to get the lower back to relax. You see a lot of patients, when they go to touch their toes, what's the first thing that has to happen when you go to touch your toes is one of the first things is we want that rib cage to depress. We want to slouch ultimately, okay? Well, you see a lot of patients present where they have an inability to depress the rib cage, they have an inability to lengthen the diaphragm, whatever you want to call it. They lead with this extension-based pattern, okay? I think even Dan Cart's, classified it maybe at some point. I remember years ago being at a conference and seeing him kind of talk about that kind of extension-based flexion, okay? I've heard Peter O'Sullivan talk about it as well. So again, in those scenarios, is their movement strategy just reacting to their inability to lengthen the diaphragm, the inability to depress the rib cage? What caused that inability to lengthen the diaphragm, depress the rib cage? That's specific to the person, okay? So again, I can't tell you today that, and I'm not saying today that the diaphragm is causing this and the rib cage is causing this. They're not. They're just simply reacting to that person's story and how their system has processed what's happening in their world, and ultimately what we're seeing in the physical body is a reaction to that. Okay, so that's maybe someone then where we want to pay particular attention to their respiratory system in particular environments. Now, we can do a lot of good things to restore the movement through the diaphragm and the rib cage, and obviously that's very, very useful in the clinic, and we can get great changes. Again, people touch their toes and be pain-free flexing for the first time in years. But the important thing is that we maintain this, and that's where then, as I said, understanding that a lot of the drivers of this, if you will, are happening as a result of that person's environment and ultimately that person's story. Okay. Then the last thing we want to talk a little bit about today, obviously, is the pelvic floor. So obviously the diaphragm and the pelvic floor, they're going to work together. So again, when we're inhaling, pelvic floor is usually ascending. We exhale, descending. When the exhale, pelvic floor is ascending. Okay. So again, when we get that diaphragm to move, the pelvic floor is going to be moving as well. Okay. So again, for me with the pelvic floor, my strategy with that is let's just get full range of motion through these tissues, and then let's put some load through these tissues, and let's get the nervous system to show that it's safe to tolerate load through these tissues, and then take them through graded exposure. Okay, and again, the graded exposure for the respiratory system may be working on some respiratory desensitization techniques in work. Actually, when there's a particular trigger, or when there's a certain somebody that causes the reactions to happen. Okay, so what I've done today is I've created a blog for you, a blog video where I look at Sarah's hip flexion. Okay, and she's a classic example where, again, when we bring her hip into flexion, she gets that kind of pinch in the front. It's quite superficial, it's not deep. So again, with that person, we may hypothesize that again, if her pelvis and is in a resting position, that's maybe reacting to a rib cage that's elevated, then is she, nipping the proximal rec fem or something like that. When we bring her knee to her chest, she gets that pinch. We get her to depress her rib cage. We keep her hands on that. We get a big difference on her hip range of motion. So that's very, very relevant clinically. So, and I like using that test personally so that I can see if I need to start up at the rib cage, the diaphragm maybe, or the lower back tissues, or around the rib cage or whatever, rather than just sticking my elbows in the glutes. So in the past, especially 2008, 2009, I'll put my hands up and gladly admit to it that in the past, when I've had someone with decreased hip internal rotation or flexion, I was putting them on the front, I was sticking my elbow in the glutes and hoping for the best. Nowadays, I've like to think of a little bit more clinical reasoning involved, working smarter, not harder, in my quest to get long-lasting results. Okay, if you don't know anything about me, these short-term changes don't impress me one bit. Okay, I've seen so many of these. I've paid thousands of pounds, wasted thousands of pounds in these courses that get short-term changes. I've brought players to the people who taught these courses. Okay, and again, what we got was short-term changes. What I'm more interested in and what I teach my mentorship and what my full system about is, not having this quick fix mentality, but earning the right to progress to the next progression, to the next level, and clinically reasoning everything we do. I'm very pro hands-on if it's used responsibly and if it's used as part of the graded exposure. Okay, I've got no problems with hands-on treatment once we do it responsibly, once we use it as part of the treatment. And what we're going to see in my mentorship especially is the first couple of sessions we may use a little bit of hands-on if it's appropriate. If it's a sensitized, persistent pain, complex patient, we may or may not. But as we get to the kind of sessions 4, 5, and 6, we're very, very little hands-on, and a lot of the treatment then is actually that graded exposure of that constant reassurance that it's safe to tolerate these loads at different loads and different speeds of movement. Okay, so again, I've gone off on a little bit of a tangent there, but the key point here today is making sure that we're getting long-lasting changes. So what I do now is we can have this real quick, simple check of the rib cage, check the hip range of motion. If that helps the range of motion, then it may be worth my time actually starting at the rib cage, or starting at the diaphragm, or starting at the pelvic floor, getting that mobility, rather than just going straight into the glutes. So hopefully that's going to help you. That's something that you can use in the clinic. And as I said, we've got a whole host of strategies to desensitize the respiratory system, to mobilize the rib cage, to desensitize a lot of these tissues to get long-lasting results in the mentorship. Okay, and again, in module 2 in particular, we spend a lot of time doing that for the lower rib cage, and in module 3 we spend a lot of time doing that for the upper rib cage. Okay, so again, the upper rib cage, just like the lower rib cage usually has a big impact on the hip. The upper rib cage will have a big impact on the shoulder joint. So again, these internal rotation tests, the sleeper stretches, you can change those within a second by changing the rib cage position. Obviously, that's all well and good, la-di-da. The big thing that I'm more interested in is keeping the rib cage in a position that's going to allow the shoulder joint to have more movement variability and be able to tolerate load in 3 planes of motion. And again, ultimately, all I want is for that rib cage to have full range of motion. Okay. So again, I'm a big believer that when we give it full range of motion, the nervous system will self-organize and it will keep it in some kind of neutral, if whatever that is, in some kind of resting position that's beneficial. Okay, so that's it for today. If you haven't already, head over to the blog. I've got an accompanying video, as I said, which will demonstrate the hip flexion test for you today. Very useful in the clinic, and hopefully it'll stop you wasting your time, maybe sticking your elbows in the glutes and just trigger some other stuff, and hopefully there's a couple of things that you might have picked up today. There's also the 6-step patient adherence checklist. Make sure you check that out. And also there's a couple of other resources there. There's loads of resources in our website. We've completely redone the website to help you increase your retention, your referrals, your reputation as becoming the go-to therapist through getting genuine, long-lasting results. So, getting paid what you're worth, growing your business ethically based on making massive, meaningful impacts on your patients' lives. Okay, and again, that's my business model. I'm a big fan of getting paid what you're worth, but also getting paid what you're worth by making massive impacts on people's lives and offering them great value. And again, if you want to know my business growth plan, that was all covered in episode 1. And to summarize my business growth plan for my clinic, it's all based on getting long-lasting results with patients. And I think when that's your main focus, the rest of it will take care of itself. But in order to have that, we need to have structure. We need to have that step-by-step system to get that patient from the initial assessment right through to the final session, to discharge them with resilience, so that we can genuinely, make massive impacts on these people's lives, change their lives. And obviously then, your retention of these people coming back to you because they trust you and they have confidence in you will take care of themselves. The referrals from family and friends because they've got the belief that you can help their family and friends. All of that stuff takes care of itself. So make sure you head over to the gotophysio.com and you can check out all the resources there. That's it for another episode. Thank you so much for your time and attention. I really appreciate it. And I appreciate you're busy and you've a lot going on. So, it's an honor to spend the time with you. Any questions, feel free to send us a message. More than happy to answer any questions. I appreciate this is one way of looking at the body. I'm not saying it's the only way, which is the beauty of our profession, but it's something that's had a massive impact on my thought process. And I've been able to help a lot of people who failed traditional approaches by looking at the body, especially low back pain patients like this, rather than probably more traditional ways that I was certainly taught in university. Okay, that's it for now. Make sure you head over to the gotophysio.com for all those resources, and I'll see you on the next episode of the Go To Physio podcast. Take care. Hey, I hope you enjoyed today's show. For more information, please visit www.thegotophysio.com, where you can download my 6-step patient adherence checklist absolutely free, as well as read the accompanying blog that goes with today's episode. We've got lots of cheat sheets and clinical content to help you implement to get real world results with real patients that ultimately helps you become the go-to therapist and allows you to build a profitable, busy private practice or become that go-to therapist in professional sport. I'll speak to you soon on the next episode.